Hello everyone, welcome to the 5th episode of our Next Gen NCLEX-RN review. Today we'll be going over 2 cases, so make sure that you have a notepad and a pen handy to take notes on the essential test taking strategies.
Before we move ahead, here's something you shouldn't miss. If your goal is to pass the NCLEX in just 1 week or 1 month, then the fastest and most effective way is to enroll in our complete online NCLEX review crash course. This course is a one-stop solution, a reliable shortcut, and a proven method with a solid 99% passing rate. More than 5,000 students have successfully passed the NCLEX by using this course. Here's exactly what you'll get: 100-hour mini crash course perfect for those who want to pass within a week. 300-hour comprehensive lectures covering 300 essential NCLEX topics that are commonly tested. 5,000 real NCLEX questions. Prepare with real exam questions and eliminate surprises. 15 full practice tests, including CAT simulations, simulate the real exam for a stress-free experience. Exclusive ebook plus 1-year access. Study whenever and wherever you want. Seats are filling up quickly. Enroll now to save 70%. Visit our website to enroll in our complete NCLEX Review Crash Course. The link is in the description. Now, let's continue with the topic.
So let's get into our Q&A. So we have here a bow tie type of question, and the scenario states, a nurse is caring for an elderly female patient at the long-term care facility. The progress notes reads at 1945, 100 hours. The nursing assistant reports that client is getting acutely confused, has become incontinent, and is trying to climb out of bed without assistance. States the client's skin feels cool and clammy, which is unusual for this client. Stage 2 sacral pressure ulcer has been worsening over the past week with beginning cellulitis. Current vital signs: temperature of 100.9 degrees Fahrenheit, heart rate of 118 beats per minute, and respirations of 24 breaths per minute. The blood pressure is 94/45. Your task is to fill in the diagram by choosing the most potential problem affecting the client, along with 2 suitable nursing interventions and 2 key parameters to monitor the success of the interventions. So we have the potential problem options here: high blood pressure, septicemia, congestive heart failure, dementia. For the nursing interventions, we have the options: encourage the client to use the call light for assistance before getting out of bed, initiate intravenous antibiotic treatment, position the client in a semi-Fowler's position, contact the provider to discuss the need for possible transfer to the emergency department, apply restraints. Now, for the parameters to monitor, the options are urinary output, erythrocyte count, vital signs, cognitive status, and cardiac rhythm. So I want you to read and thoroughly scan through each option. Make sure that you're not going to neglect any potential leads to finding that correct answer. So, what do you think would be the potential problem here? Well, the answer to that is septicemia. This is a life-threatening condition that is caused by a systemic infection that enters the bloodstream, and this can lead to widespread inflammation, can cause third spacing. This can cause that widespread or systemic inflammatory response because of the release of those chemical mediators. This can lead to massive vasodilation, and fluids will go into the intracellular spaces, interstitial spaces, causing a significant drop in the blood pressure, and this can lead to overall drop in the perfusion to the bodily organs. Now, the client's vital signs, including the temperature of 100.9 degrees Fahrenheit, that's fever, there's that tachycardia of 118, and also the respirations of 24 breaths per minute, and the blood pressure of 94/45. Those are significant vital sign changes, especially that the client also is manifesting the cool and clammy skin And take a look at this phrase, which is unusual for this client. Now, do not neglect about the stage 2 sacral pressure ulcer that has been worsening over the past week. So this suggests a localized infection that may have progressed into a systemic involvement. And the older adult that we have in this case is at increased risk of developing the sepsis due to their weakened immune responses and their chronic conditions. Now, why is congestive heart failure an incorrect answer? Well, it's because congestive heart failure typically presents with fluid overload. Clients will end up with pulmonary congestion. There's going to be presence of crackles in the lungs, edema, and none of which are noted in the case. And the dementia is also incorrect because the client has acute confusion. Pay attention to here. Acutely confused, which is a hallmark sign of an infection in the elderly rather than a chronic cognitive decline that you will typically see in a patient with dementia. Now, the blood pressure, this is already hypotensive, right? Which is an early warning sign of septic shock rather than hypertension. Now, for the nursing interventions, one of the answers here is to contact the provider to discuss the need for a possible transfer to the emergency department, because sepsis itself is a medical emergency that requires immediate hospital treatment. That includes IV fluids, maybe vasopressors, and also aggressive antibiotic therapy, especially if the client has that wound. And also, the client's vital signs indicate early sepsis, which can rapidly deteriorate into a septic shock. And this patient definitely needs a transfer, a prompt transfer to the ED for timely blood culture collections, also resuscitation of the fluid, and the administration of antibiotic to prevent organ failure. Now, we're also going to encourage the client to use the call light for assistance before getting out of bed. It's because of the acute confusion. This increases the client's fall risk, especially that she is an elderly person with hypotension and, of course, the weakness. And this falls can also lead to complications. It can lead to fractures, head injuries, maybe additional skin breakdown. Now, why is the application of restraints incorrect here? It's because restraints are last resort, and this may increase agitation to the client. It can increase delirium, especially can increase the risk of injury in confused patients. So what we'll do instead is to do frequent monitoring, frequent reminders, and we also need to modify the environment. We're going to have to activate the bed alarms. And these are things that you need to prioritize before you do application of the restraints. All right. Now, what about initiating intravenous antibiotic treatment? Why is this inappropriate? Well, it's because nurses in long-term care facilities cannot independently initiate treatments like IV antibiotics, even in the acute care settings. And even though we know that antibiotic treatment is critical to the management of sepsis, but with this action, this requires a provider order or the healthcare provider's order, and you're only going to administer this specifically if blood cultures are already completed. And this is something that is usually going to be started in the acute care setting. So once the client has already been transferred to the acute care facility. Now, we also have to make sure that blood cultures are obtained before the antibiotic administration to ensure that there is appropriate treatment. And then again, this is something that will be carried out in the acute care setting once the client is transferred, right? Now, what about position the client in a semi-Fowler's position? We know that this is something that can help a client that may have issues with breathing, but it does not directly address the priority issue of sepsis. What the client needs this time is fluid resuscitation and the management of sepsis rather than postural adjustment or this is not really going to help the client this time. Now, for the parameters to monitor, one of the correct answers here is the urinary output, because with decreased urinary output, less than 30 mL per hour, is an early sign of septic shock and organ dysfunction. And with kidney perfusion being decreased due to the drop in the blood pressure and the fluid shifting, this is going to make the urine output a critical marker for the progression of the sepsis. Now, the other answer here is the vital signs. So, because of the fever that the client is having and the tachycardia, there's also hypotension. These are key indicators, and so we have to monitor the client's vital signs to detect any worsening or if there is any improvement of the client's status. And so the continuous monitoring is very essential to detect the sepsis, especially. Now, why is erythrocyte count incorrect here? The reason for that is because sepsis affects the white blood cells more than the red blood cells, and the red blood cell count is not a primary indicator of infection status. Now, the continuous or the cardiac monitoring right here, this option, this is basically going to require the nurse to start the cardiac monitoring continuously, which is not really the most sensitive marker for sepsis progression. And take note that the sepsis primarily affects the hemodynamics and perfusion. So this makes the vital signs and urine output monitoring more critical. Now, pay attention that the client is residing at the long-term care facility. So before the transfer, the facility, basically, they're not typically equipped with the telemetry for continuous cardiac rhythm monitoring, and the use of such equipment is more common in the acute care facility, in the hospital, particularly med-surg with telemetry, progressive care unit, ICU, ED, but not in the long-term care facility. Now, the cognitive status is also incorrect. Even though cognitive changes can happen with a sepsis, the vital signs and the urine output offer more objective ways to assess the severity, and the client's confusion may continue until the infection is resolved. And so for this test question, I want you to go look and pay attention to the critical cues. There's that acute confusion, which is basically a sudden cognitive change in this elderly client, suggesting that there is an infection going on. The tachycardia and the respiration, that is 24 breaths per minute. The hypotension of 94/45. This indicates early shock. All right. And the fever as well, the cold, clammy skin indicate poor perfusion. And also the worsening of the sacral pressure ulcer with cellulitis, which is basically the source of infection. And so when a test question provides you with so many multiple selections or options, make sure that you think and also carefully select among these options, and especially that this is pointing more towards the sepsis, which is the potential diagnosis. And don't forget about the ABCs, airway, breathing, circulation. And this client has a problem with circulatory compromise due to the hypotension and tachycardia, increasing respirations as well. And do not neglect the use of the ADPI this time. Also, do not forget about the use of the Maslow's hierarchy of needs. Sepsis is a physiologic emergency, and also integrating into the patient safety. That is why we have to encourage the client to use the call light for assistance before getting out of bed. And this is going to be integrated with the other interventions as well. And so if the client shows early signs of sepsis, your intervention should be done immediately to prevent septic shock and other multi-organ failure. And don't forget about eliminating the incorrect answers here, especially with the potential problem. We have dementia. This is incorrect because what we have in our case is an acute confusion. Whereas if if we are selecting dementia, dementia is going to occur in a progressive manner. There is that chronic cognitive decline. Now, for the congestive heart failure, this is also incorrect because the client have no signs of fluid overload. There is no pulmonary congestion nor even edema. And the application of restraints is incorrect because this can worsen the client's agitation and delirium. So we definitely need to use alternatives like frequent monitoring and call light reminders instead, possibly activation of the bed alarm. And if a condition is acute and if it's rapidly worsening, your intervention should focus on immediate medical treatment rather than for long-term management, such as dementia care. And the strategy that you're also going to use is to make sure that you are using those options that directly address the life-threatening issue. Okay, so calling the medical provider would be the key here, so we can obtain more orders for treating the sepsis.
Before moving ahead, I have some exciting news for you. If you are determined to pass the NCLEX within a week or a month, then your best option is to enroll in our complete online NCLEX Review Crash Course right now. This course is a comprehensive all-in-one solution, a guaranteed shortcut, and a proven method to pass. Over the last 5 years, more than 5,000 students have successfully cleared their NCLEX exams using this course with an impressive 99% passing rate. Here's what you'll get: 100-hour animated mini crash course, ideal for those who have limited time and want to pass in just 1 week. 300-hour comprehensive recorded lectures covering 300 high-yield NCLEX topics that the exam loves to test. 5,000 real NCLEX questions, practice with actual past exam questions for better preparation. 15 full-length practice tests, including CAT simulation. Feel confident before your real exam day. Exclusive NCLEX ebook, the ultimate guide you need to pass. 1 year full access. Study anytime, anywhere at your own pace. This is a limited time offer. Enroll now to grab 70% off. Visit our website to enroll in our complete NCLEX Review Crash Course. The link is in the description. All right, now let's dive into the topic.
Let's have the second case. A 58-year-old with poorly controlled type 2 diabetes, hypertension, hyperlipidemia, and peripheral vascular disease is undergoing their first peritoneal dialysis session after catheter placement 3 weeks ago. They have a history of poor self-care, irregular diet, and inconsistent insulin use with recent symptoms of nocturia, proteinuria, reduced urine output, swelling, muscle weakness, and cramps. The progress notes reads at 10 a.m. The patient is alert and oriented, having eaten breakfast at 6:45. Vital signs: temperature 101.2 degrees Fahrenheit, heart rate 99, respirations 20, blood pressure 188/122, saturation of 93, room air. Reports a throbbing headache and peritoneal site pain, 3 out of 10. Height 5'11", weight 238 pounds. Appears confused about the first dialysis session. Has 1+ lower leg foot edema. Clear lung sounds. Soft abdomen. Bowel movement yesterday. Overnight urine output 40 mL. EKG heart rate of 100 beats per minute. Tall. Peak T waves. Flat P waves. Widened QRS and prolonged PR interval. Denies chest pain. Your task is to choose the assessment finding that best corresponds to each of the client's health conditions. All assessment findings must be assigned, and some may be used more than once. So we have the clinical findings here: hemoglobin of 10.4, potassium 6.8, weight 238 pounds. Urine output of 40 mL overnight, 1+ edema in both lower legs and feet. The glomerular filtration rate of 28 mL per minute. Confusion about the first dialysis session. Postprandial serum glucose of 134. Hemoglobin A1C greater than 10%. Blood urea nitrogen 66 milligrams per deciliter. Creatinine of 4.8 milligrams per deciliter. Sodium of 147 milliequivalents per liter. And we have the following conditions that the client is currently having: peripheral vascular disease, chronic kidney disease, and diabetes. Again, you need to assign these clinical findings to the client's condition. So let's take a look into the hemoglobin of 10.4. What do you think about this one? Is this much more associated with PVD, CKD, or diabetes? Well, the answer is chronic kidney disease. This is mild anemia, and this is explained by the chronic kidney disease, which is the damage of the kidneys. And the kidneys will produce less erythropoietin, so this can lead to a reduction in the red blood cell production. And why is it not PVD or peripheral vascular disease? Well, the PVD does not affect erythropoietin or the hemoglobin levels because it involves circulation rather than kidney function. And diabetes is also inappropriate because diabetes may only contribute to anemia indirectly over time, maybe through microvascular damage, but it is not the primary cause here, especially without any evidence of acute diabetic complications. Now, for the potassium of 6.8, do you think that this is appropriate to all three of them or maybe just one? Well, this is only going to be assigned to the chronic kidney disease. That elevation of the potassium level is due to the chronic kidney disease because with impaired kidney function, this kidney or the kidneys will fail to excrete the potassium effectively. And the peripheral vascular disease does not influence potassium regulation, and the diabetes typically can cause hyperglycemia, may lead to hypokalemia in some acute states, especially with a DKA treatment, but not hyperkalemia. Now, what about the weight of 238 pounds? Is this something that will be associated to just one, maybe two, or three? Well, the answer to that, it's going to be associated to the chronic kidney disease. And why is that? Well, it's because the increase in the weight could be due to the edema that the client is having. There is 1+ edema, reflecting that there is fluid retention from the CKD due to poor kidney filtration. And of course, the client has peritoneal dialysis. I mean, not peritoneal dialysis, but rather end-stage renal disease. They're not going to be able to excrete the fluid volume that they're supposed to. And so that can lead to some retention of fluid in the cardiovascular system. Now, what about the diabetes? Will it affect the weight? Yes. It's because diabetes can contribute to the body by causing some osmotic effects. And with poor glycemic control, this can lead to fluid imbalances and possibly it can lead to fat deposition as well. And so, again, the PVD, which is one of the conditions, cannot cause some significant weight gain or any fluid retention because it affects blood flow rather than fluid regulation. Now, for the urine output of 40 mLs overnight, this is a low volume. And so this is going to be associated with the chronic kidney disease. As we know that the client has an advanced kidney dysfunction as a direct result of the chronic kidney disease. The kidneys have lost their filtering capacity. And for PVD, this is incorrect because PVD does not affect urine production. And diabetes may increase urine output in the early stages due to the glucosuria or glycosuria, but the decreased urine output in the assessment doesn't align with the diabetes, and that's why it's inappropriate to select diabetes this time. Now, let's take a look into the 1+ edema in both lower legs and feet. Do you think that this is going to be associated to all? Well, this is something that can be associated to both PVD and also the chronic kidney disease. Well, it's because the edema results from the accumulation of fluid due to the overload, and of course with a kidney function that is impaired. And the PVD contributes the 1 plus edema by impairing the venous return and circulation in the lower extremities. Now, diabetes may cause edema indirectly through vascular damage over time. Okay, I'm talking about over time, but this is not the primary driver here because the edema is more closely associated to the renal and circulatory factors. Now look into the GFR of 28 mLs per minute. Do you think that this is associated to 1, 2, or 3? Well, this is directly tied to the chronic kidney disease. Well, this is basically reflecting that the patient has stage 4 chronic kidney disease. It reflects severe kidney impairment, and the peripheral vascular disease does not affect PVR. It is not, because it is a vascular condition unrelated to kidney filtration, and the diabetes can damage kidneys over time, but the specific GFR value is a marker of the chronic kidney disease progression, not an acute diabetic progress. Now, for the confusion about the first dialysis session, what do you think about that? Well, this is something that is closely associated to the CKD because this could result from the uremia, maybe a buildup of some toxin, maybe the blood urea nitrogen. Yeah. And of course, due to the chronic kidney disease, and these are linked to the renal failure. Well, the PVD does not cause cognitive changes because the changes will focus more about the circulation here. Now, for the diabetes, this might lead to confusion in severe hyperglycemia or hypoglycemia, but the postprandial that we have here basically is normal, making the chronic kidney disease the likely cause. Now let's take a look into the postprandial value itself, which is 134. What do you think about this one? Well, this is closely associated to diabetes. And again, this reflects diabetes management and glycemic control. The peripheral vascular disease does not influence glucose levels because it is a circulatory issue. The CKD may affect glucose metabolism in advanced stages, but this is expected value is specific to diabetes monitoring. Now, what about the HbA1c, which is greater than 10%? This basically reflects poor glucose control in the long term, and this is a hallmark of diabetes. And again, PVD does not affect hemoglobin A1c, and CKD isn't also the perfect match. It may alter glucose levels in end-stage renal disease, but hemoglobin A1c is a specific marker of diabetes control. Now for the BUN, this is going to be matched to the chronic kidney disease because this is going to reflect impaired kidney function, which is a key indicator of CKD, not PVD, not diabetes. The same thing with the creatinine level. This is 4.8 milligrams per DL. With this elevation, this signifies that there is significant kidney damage, a primary marker of CKD. And the peripheral vascular disease does not influence creatinine because it is a vascular condition. For diabetes, it can lead to kidney damage over time, but the high creatinine is a specific indicator of kidney function. Now, what about the sodium here of 147? Do you think that this is associated with a 3? Well, the answer to that is that it is going to be on CKD. There's going to be mild hypernatremia as a result from the CKD related to dehydration or possibly altered fluid balance due to the reduced kidney function. And the PVD does not affect sodium levels, so you got to eliminate that as well. And same thing with diabetes. The diabetes can typically cause hyponatremia or possibly normal sodium in acute states, not hypernatremia unless it's complicated by other renal issues tied to the CKD. So for this type of question, I want you to carefully match the clinical findings to the chronic kidney disease, the diabetes, peripheral vascular disease, and don't forget to use the concept of pathophysiology. All right. So never neglect using the pathophysiology in this type of question. And you have to eliminate those incorrect options. You have to rule out conditions that do not align with the pathophysiology. All right, so that's it. And I hope that you have learned something from this Q&A. So be sure to like and to share this presentation. Share your thoughts on the NGN questions in the comments below, and I'll see you again in the next session.